When a major blood vessel breaches inside the human digestive tract, the resulting internal hemorrhage is fast, chaotic, and completely hidden from view. This diagram illustrates the strict anatomical boundary that defines upper gastrointestinal bleeding. It is any hemorrhage originating above the suspensory muscle of the duodenum, clinically known as the ligament of Treitz. This territory restricts the focus strictly to the esophagus, the stomach, and the duodenum. A bleed within this upper tract is one of the most frequently encountered and potentially fatal surgical emergencies in clinical practice. Unlike standard diagnostic medicine, where testing dictates the treatment, managing this crisis requires a complete inversion of the usual rules. Here, resuscitation must precede diagnosis. Before a physician ever attempts to insert an endoscope to locate the specific source of the bleeding, their absolute priority is maintaining systemic blood pressure to keep the patient's brain and vital organs perfused. Survival depends on strict adherence to a chronological algorithm of hemodynamic stabilization, prioritizing systemic balance over immediate surgical intervention. The patient's physical presentation provides the first estimate of the hemorrhage's severity. Vomiting fresh red blood, hematemesis, indicates an active, severe hemorrhage. If that blood has been altered by gastric acid, it presents as coffee ground vomitus. Further down the tract, digested blood exits as a black, tarry stool known as melena. For melena to manifest visibly, it requires an internal loss of approximately 50 to 100 milliliters of blood. The passage of fresh blood per rectum, hematochezia, typically points to a lower GI source. However, if an upper GI bleed is massive enough, the rapid transit of blood through the system can also present as hematochezia. While these visual markers indicate a source, they do not quantify the physiological impact of the blood loss. To determine the actual volume lost, clinicians must look strictly at the patient's vital signs. This matrix maps the physiological indicators of hemorrhage severity. In cases of mild blood loss, meaning less than 15% of total volume, the patient's blood pressure remains normal, accompanied by only mild tachycardia. When the volume lost crosses into the 15 to 30% range, it qualifies as moderate blood loss. The defining clinical shift here is the onset of postural hypotension, where blood pressure drops significantly when the patient changes position to stand. Severe blood loss occurs when the hemorrhage exceeds 30% of total volume. This manifests as outright hypotension, clinical shock, and an altered sensorium due to a critical lack of cerebral perfusion. Attempting to visually estimate the volume of blood in vomit or stool is notoriously inaccurate. It is these isolated, objective shifts in vital signs that trigger the trauma protocol. The first step in that protocol is the ABC approach. Securing the airway is the absolute priority, often requiring intubation if the patient presents with massive hematemesis or altered consciousness. Once the airway and breathing are secure, the focus shifts to circulation. The immediate mechanical requirement is establishing 2 large-bore intravenous cannulas for rapid volume replacement. Clinicians initiate fluid resuscitation using crystalloid solutions, specifically normal saline or Ringer lactate, to rapidly restore intravascular volume. If the hemorrhage is severe enough to require blood, modern practice dictates a strategy of restrictive blood transfusion, replacing older, aggressive transfusion models. This gauge illustrates the current transfusion triggers. For the general patient population, the standard threshold to initiate a transfusion is a hemoglobin level dropping below 7 grams per deciliter. The exception is for patients with ischemic heart disease or those experiencing ongoing massive bleeding, where the threshold is raised to 8 grams per deciliter to ensure adequate cardiac oxygenation. Concurrently, a full panel of baseline labs is drawn. These include blood urea nitrogen levels, which help differentiate the source of the hemorrhage. This flow path details the mechanism. When red blood cells pool and digest in the gastrointestinal tract, the breakdown of those proteins significantly increases systemic urea production. Consequently, an isolated, elevated blood urea level strongly predicts an upper GI source. Securing robust intravenous access and establishing these baseline laboratory values forms the absolute physiological foundation before any mechanical intervention is attempted. With the patient resuscitated, clinical decision-making relies entirely on validated scoring systems to eliminate subjective bias. The primary tool used initially is the Glasgow-Blatchford score. As seen on this timeline, the Glasgow-Blatchford score is calculated strictly before endoscopy. It utilizes basic vital signs and lab parameters, like hemoglobin and urea, to predict the need for medical intervention and the risk of adverse outcomes. In contrast, the Rockall score occupies the second phase of the timeline. The Rockall score is calculated strictly after endoscopy is complete. It predicts the risk of rebleeding and overall mortality by incorporating the patient's age and comorbidities, along with the actual physical findings from the endoscopic exam. In practice, the Glasgow-Blatchford score dictates exactly who needs to be scoped and how urgently, while the Rockall score dictates how closely they must be monitored in the days that follow. The definitive procedure connecting both of these scoring systems is endoscopy. It serves as the diagnostic and therapeutic gold standard and should ideally be performed within 24 hours of initial stabilization. When the endoscope reaches the upper tract, the most frequent etiology encountered is peptic ulcer disease, which accounts for up to 60%. This system provides a standardized language for clinicians to communicate the exact morphology and the corresponding bleeding risk of a peptic ulcer. The highest risk categories demand immediate intervention. These are Forest Class IA, characterized by active arterial spurting, and Class IB, which shows active oozing. The intermediate risk categories include Class 2A, where a non-bleeding visible vessel sits in the ulcer bed, and Class 2B, which presents with an adherent clot covering the lesion. Managing these high-risk ulcers requires a three-pronged approach. First, direct endoscopic hemostasis is achieved via adrenaline injection, thermal coagulation, or mechanical hemoclips. Second, the patient is started on high-dose intravenous proton pump inhibitors. Finally, the underlying cause is treated through the eradication of H. pylori bacteria. Mechanical clipping or cauterization of an ulcer is simply insufficient on its own. It must be paired with intense pharmacological acid suppression to prevent the newly formed clot from dissolving. The therapeutic pathway diverges entirely if the endoscopy reveals the second major etiology of upper GI bleeding, esophageal varices resulting from portal hypertension. Unlike an ulcer, which is a focal injury, varices require immediate systemic pressure management. The first step is administering splanchnic vasoconstrictors, such as terlipressin or octreotide. This visualization shows the precise mechanism. Terlipressin chemically constricts the splanchnic blood flow. By restricting the volume of blood entering the splanchnic bed, it mechanically reduces the portal venous pressure that is causing the varices to rupture. Alongside pressure management, it is absolutely essential to administer routine prophylactic antibiotics, like ceftriaxone, to prevent severe infections common in this specific patient population. Once the pressure is partially controlled, endoscopic band ligation becomes the mechanical treatment of choice to tie off the bleeding vein. Older methods, like balloon campanade using a Sangstack and Blackmore tube, are now reserved solely as a temporary bridge to definitive treatment. Variceal bleeding is a plumbing pressure problem. Without pharmacological inflow reduction to relieve the system, any attempt at mechanical banding will ultimately fail under the pressure. While endoscopic therapies resolve the vast majority of upper GI bleeds today, open surgery remains a mandatory salvage pathway for patients with persistent bleeding, hemodynamic instability, or massive ongoing transfusion requirements. The classic surgical scenario, and a staple of medical examinations, is the massively bleeding duodenal ulcer. This diagram illustrates the perilous anatomy of the posterior duodenum. An ulcer here can erode straight through the mucosal wall and directly breach the underlying gastroduodenal artery, resulting in catastrophic hemorrhage. The definitive surgical management for this breach requires a duodenotomy to open the tract, followed by direct surgical ligation of the bleeding vessel and underrunning of the ulcer bed to secure the tissue. This differs significantly from bleeding gastric ulcers, which often require a wedge excision or partial gastrectomy. In the stomach, the excised tissue must be thoroughly biopsied to conclusively exclude an underlying gastric carcinoma. When specialized endoscopic tools cannot overcome a major arterial breach, open surgical ligation acts as the final definitive barrier against exsanguination. From the first intravenous line to the final hemoclip, the entire upper GI bleeding protocol is a tightly synchronized algorithm designed to outpace three major complications. The immediate physical threats are hypovolemic shock and secondary acute kidney injury, both driven by prolonged systemic hypoperfusion. The longer-term threat is rebleeding. It stands as the single greatest driver of overall mortality, especially among elderly patients or those with pre-existing comorbidities. Successful management of upper GI bleeding requires a transition from simple lesion identification to the flawless execution of an algorithmic resuscitation.